morning. Before we begin today, I would like to acknowledge the traditional owners of the land that we are standing on today, the Whadjuk people of the Noongar Nation, and pay our respects to elders past, present and future. So welcome and thank you for joining us today. My name is Vilma Fitzgerald and I am a Senior Research Officer with the Australian Indigenous Alcohol and Other Drugs Knowledge Centre, which is located at the Edith Cowan University on the Mount Morley campus in Western Australia. So today's presentation is one of the series of webinars produced by the Alcohol and Other Drugs Knowledge Centre, which is funded by the Department of Health. And we are pleased to introduce our guest presenter, Dr. Jane Fischer, who is a research fellow at the National Centre for Education and Training on Addiction, which is located at Flinders University in South Australia. Now, Dr. Fischer has worked in the AOD field for over 20 years in both Adelaide and Brisbane. And prior to her current position, Dr. Fischer was the Program Manager for the Centre for Drug and Alcohol Studies located at Biala, Queensland Health. And the program that Dr. Fischer managed was responsible for evaluating and implementing Smoke Check and the Indigenous Risk Impact Screen. So good morning, Jane, and welcome to everyone.
Good morning, Vilma, and thank you for that kind introduction and welcome everyone too. Thank you for joining us today.
No problems. And now what I'll do is I will switch off my webcam and microphone in just a moment. Please advise that the chat option will be switched off and we'll take questions at the end of the presentation. So I'll hand over to you now, Jane. Thank you.
Thanks, Vilma. Firstly, I would like to begin by showing my respect by acknowledging the traditional owners and custodians of the land both here where NCETA is located at the Kaurna Nation, but also in the countries where this webinar is being watched today. As Vilma pointed out, NCETA is located in Adelaide. It's one of 4 national centres focusing on alcohol and other drugs. You may, particularly if you're from WA, know of NIDRI, but also NDARC in Sydney and Turning Point in Victoria. NCETA's work focuses on research translation and primarily alcohol and workforce development. And I focus on a little bit of that today. And like the Indigenous AOD Knowledge Centre, we're also funded by the Australian Government Department of Health and Wellbeing, Australian Government Department of Health, but also by Flinders University. I'd like to acknowledge that this webinar draws extensively on the work of others, in particular actually the work of the Indigenous AOD Knowledge Centre in their review of the harmful use of alcohol amongst Aboriginal and Torres Strait Islander peoples. Also the work of Marmot and Wilkinson's classic text and classic studies around the social determinants of health. Primarily it started in the England, but has been widely now used in Australia as well. And more recently, NCETA's own work examining the social determinants of inequity in alcohol consumption and alcohol-related harm in Australia and elsewhere. The seminar is basically divided into 3 parts. The first part, patterns of alcohol use, will be very brief, which is quite different to what you would normally get, but I'll explain why in a moment. The second part describes and defines inequity in the social determinants of health. And finally, the third part considers alcohol-related interventions and also supporting alcohol and other drug workers and Indigenous health workers through an equity lens. Now, in terms of this first part, let's turn to patterns of alcohol use. Now, I'm not actually going to go into detail here regarding how many Aboriginal and Torres Strait Islanders do and do not consume alcohol. Rather, I would like to draw your attention to this brilliant, and it's actually a very short video, developed by Etherington and colleagues for the Australian Indigenous HealthInfoNet. The video draws its information from that review I mentioned earlier. It's actually quite brilliant. But what I would take from that for this webinar is what's articulated in the video is how Aboriginal and Torres Strait Islander people are more likely to abstain from alcohol and less likely to consume alcohol at risky levels than non-Indigenous people. However, alcohol is associated with a disproportionate amount of harm and burden of disease amongst Aboriginal and Torres Strait Islander peoples. So why is this so? In short, many would argue increasingly that it has to do with inequity and what determines our health, its determinants. If we turn first to inequity, When we say inequity, we mean the differences that are unfair and unavoidable, but are absolutely amenable to change. This differs from equality, as illustrated in this picture from Canada. If we are to be equal, the same resources are given to everyone. However, that does not necessarily mean everyone gets an apple. In contrast, if resources are equitably distributed and deliberately so, everyone has an equal opportunity to reach for, grab, and if they want to, eat an apple. Another way of looking at inequity and equity is looking at social and economic conditions and their effects on people's lives. Quite often we focus on the problem and what the problem is, but when we take an equity perspective, the other side of that coin is that also that social and community action can be taken to prevent people becoming ill or treating illness if and when it does occur. This slide is from a presentation by Fran Boehm, who leads the Southgate Institute here at Flinders Uni. And this is a conceptual model of the social determinants of Indigenous health and social inequities. If you like, it's a big picture at a macro level. But what it does, it illustrates how policy, social and economic conditions, colonisation and separation from land, family, community and culture all influence health behaviours and psychosocial factors, in short, health and well-being. What I would like to add to this conceptual model is that this component where it says outcomes down in your right-hand corner of the screen, that actually then feeds back into those policies, into those key determinants. So it's very much a cycle that occurs as opposed to being linear. Now these conditions here named the key determinants are termed the social determinants of health. These are the conditions in which individuals are born, grow, live, work and age. Now, according to Marmon and Wilkinson, there are 9 social determinants of health. 4 I will particularly look at today because they are particularly relevant to looking at alcohol related alcohol interventions and inequity. The first is known as the social gradient. And this occurs in all communities and all populations. The social gradient says that at each aspect of the social scale, the lower the step, the lower one's life expectancy, and more common is disease and disability. Now this what is up on your screen is a figure of maternal morbidity in 3 countries, Tanzania, Peru and Indonesia. In each of those groups of slides, the purple bar is the group at the highest end of the socio-economic scale, and the blue bar is the group at the lowest end of the socio-economic scale. As you can see, no matter what country, maternal morbidity is lowest in the purple group and highest in the blue group. Basically, this is the key message around the social gradient, is that globally, both richer and poorer people have more in common with richer and poorer people in other countries than they do with poorer or richer people in their own country. Now, this is another way of looking at the social gradient, and I often use this with students, particularly social work students and nursing students, to illustrate that we are actually all in this together, that being a professional does not make you immune to the effect of the social determinants of health. The social determinants of health affect all of us. What this figure shows that even in a country that is wealthy, in this case Sweden, if you have a doctorate, you are more likely to live longer than even someone with a postgraduate degree, who in turn is likely to live longer than someone with, and I put this in parentheses, only an undergraduate degree or only with a Year 12 education. Alternatively, what this also shows, and what's not often brought up, is that it also shows how important education is to mortality and morbidity. The higher the education level, risk of dying younger reduces, even if that is from compulsory to vocational education. The second social determinant that Marmon and Wilkinson talks about is that of stress. Now, stress, arguably, there is good stress and there's bad stress. But what they particularly focused on was on that acute and chronic stress. And what they highlighted and emphasised is that acute and chronic stress ripples across not only individuals, but also families and communities. It's like a stone thrown into a water that just permeates as far as the water may go. This slide here shows some of the effects of acute negative stress on the body, both in terms of the biological aspects of the body, but also in terms of other elements of the body as well. This book at the side, The Words the Body Keeps the Score, is actually a recent book. It's really fascinating. I urge you to read it. That looks particularly at post-traumatic stress disorder and cumulative trauma on the body, even after years of the first traumatic event. Essentially, it shows that even effects of childhood can have a cumulative effect on the body and what happens to one's body. For some, it may be, for example, I know myself, there's a level of stress I get which is historical, and I know that constantly affects my body now and makes my body a bit iller than it was even 2, 5, 10 years ago. A third gradient, third social determinant of health, and what Marmot and Wilkinson pointed out, was social exclusion. However, since then, many others have also pointed out the role of racism in determinants of health and in those conditions, because there is consistent evidence of a strong relationship between experiencing racism and poor mental health. Indeed, even a recent Victorian population study estimated that the effect of racism was equivalent on physical and mental health as was being a regular tobacco smoker. Now, this then now becomes a bit more complicated because Marmot and Wilkinson also added addiction, and I put that in parentheses, as one of the social determinants of health. So in effect, it's an individual factor that determines health, but it's also part of that bigger macro picture. Harmful use and dependence are both a response to social disadvantage and distresses, but they can also lead to further disadvantage. And that's why I pointed out in that model that it can go backwards. It cycles back into those issues of policy and certainly around stigma and discrimination. And what we do know, particularly from the work recently that Roach and colleagues and myself have done, is that different populations have differential levels of alcohol consumption, as well as differential vulnerabilities to alcohol-related harm. Now, this occurs right across the board. Even here in Adelaide, recent work we did for the PHN demonstrated that in some areas that are very high socioeconomic status, have very high levels of risky drinking, there isn't actually that much relatively harm. But in other areas which are very low socioeconomic status, where actually there's very little risky drinking occurring, the amount of harm is disproportionate. So what that means, if you recall earlier, that question is, why is there a disproportionate level of alcohol-related harm, given the small proportion of Aboriginal and Torres Strait Islander people who consume alcohol? The answer is short, is due to the inordinate amount of discrimination, stress, poverty, ongoing grief and trauma that is experienced by individuals, families and communities. Alcohol-related inequalities and harm arise within, but also as a consequence of socio-economic position. And I'll say at this point, probably you guys already know this, that I'm actually I'm probably speaking to the converted, but hopefully what this is doing is reconfirming some of your thoughts and ideas and evidence that you see in the communities in which you work. So what do the social determinants of health mean at a service provider level and at the work that an AOD worker or an Indigenous health worker does? In other words, how does equity and inequity shape the delivery of alcohol-related interventions and the Indigenous AOD and health workforces? Well, quite simply, if we're looking at that macro level, but also at that micro level, is that in terms of interventions, the cornerstone principle that's required was stated by Dennis Gregg and colleagues for the Australian Indigenous HealthInfoNet, in that interventions need to address the issues of discrimination, stress, poverty, ongoing grief and trauma, and colonisation. Interventions that do not address these issues are unlikely to result in lasting and permanent change. So in short, to reduce alcohol-related harm, we also need to remove discrimination, decrease the level of stress, decrease poverty, work with and address ongoing grief and trauma and colonisation. In terms of specific interventions, NCETA conducted a review of the impact of equity on various alcohol-related interventions about 18 months ago. Now, we were actually overall really surprised with the lack of research at that point in this area. There was very little peer-reviewed literature out there, very little evaluations or work done around it, which was incredibly surprising to us. Nevertheless, in terms of what we found, we categorised the evidence into 5 categories. Those with the greatest evidence, the greatest potential equity impact, those with weak to moderate impact on equity, neutral, some that may actually worsen inequity, and those that require further research. The ones with the greatest are in terms of how we address things such as town planning, zoning and licensing to prevent the clustering of outlets. So we know from the literature that liquor outlets are more likely to be in areas of social and economic disadvantage. But it's also about how we plan our cities and how we plan our urban areas and our communities, how we zone for areas for children, how we zone areas for the whole community to be together. And also what we do know from the limited literature is that socio-economic interventions targeting vulnerable people make a difference in terms of alcohol-related harm. Interestingly, where there was actually very little research, where further research is required, is in terms of better understanding cultural context of alcohol consumption. Issues around alcohol trading hours, around social participation activities such as sport, how alcohol marketing and advertising, around the issue of fire alarms, and also around issues of ignition locks, impounding vehicles and courts. Now, in terms of supporting AOD workers, what does the social determinants of health and equity lens means for your work? In the last couple of years, NCETA has conducted a broad range of work with primary health networks, primarily in the Northern Territory, in South Australia and in Queensland. And what was apparent right across the board was that no matter where Indigenous AOD workers were located, whether it was the city, where it was in the most remotest areas, whether it was Northern Territory or South Australia, the nature of their work in terms of inequity was very similar, in terms of very heavy workloads, stigma, experiencing stigma in terms of racism, but also in terms of the work itself around AOD work. Issues around boundaries and roles and the lack of clarity in those areas, isolation, particularly amongst remote workers, and working with clients with complex concerns. Now, as part of that work that we did, when we look at an equity lens in terms of supporting and building capacity and developing the Aboriginal and Torres Strait Islander AOD workforce, what was very clear was there was about 8 things that can be done from a systems approach. So this is not about focusing simply on the individual, but also on the workplace and the policies and procedures that underpin where a person works, in terms of providing culturally safe and secure workplaces and maintaining culturally safe and secure workplaces, building a local future workforce, so means of providing opportunities for students in 8, 9, 10, 11, 12 to participate in some way in the work of the health centre or the AOD or with AOD workers. Developing innovative employment conditions, for example, leave provisions, and initiate and ensuring ongoing clinical supervision and mentoring. The other key aspects which was identified in terms of looking at workers was clarifying the scope of practice, particularly for remote workers. There being a organisational commitment, a service provider commitment to professional development of all staff, and making sure that that's done in innovative ways. So also supporting staff to undertake higher qualifications. Delivering relevant education and training opportunities that are relevant on the ground. As someone pointed out in one of the PHN studies, quite often what's delivered by trainers in their neck of the woods was something that was delivered in a big city, was developed in a big city. It had little acknowledgement or understanding of cultural needs, cultural responsibilities. It had no understanding of that the alcohol and other drug use is such as simply one aspect of looking after and caring for a whole person and a whole community and a whole family. And also providing leadership opportunities. So in conclusion, no doubt I've been presenting to the converted, as I said. Many of the issues I spoke about are what you would be very familiar to you all. Perhaps it's also reconfirmed your own thinking and concerns. In particular, in summary, what this, altogether this presentation is the takeaway is that opportunities to be healthy are actually not equally distributed. Health inequity is due to the unequal distribution of power and resources across the life course, and these are amenable to change. And social determinants of health influence exposure and vulnerability to a range of potentially health-damaging behaviours and conditions, risky alcohol consumption being one of them. And finally, that social determinants of health affect everyone, clients and workers alike. I'll pass back to you, Vilma.
Thank you, Jane. That was very interesting and informative. We'll turn our videos back on so that we can see Jane and myself. I hope you can all see us now. And what we'll do is we'll have an opportunity to take some questions. If you would like to ask Jane any questions, please type them into the Q&A icon, which is located on the bottom of your screen. Alternatively, we have Jane email details on screen. So do you mind if people get in touch with you directly, Jane?
Please do.
Yeah. Okay, great.
Thank you.
So just go to the next slide. Thank you, one.
Oh, sorry.
No, you're right.
This is a joint effort.
It is,
and I'm letting the team down.
No, that's okay. That's no problems. So we've just got some questions coming through.
Lovely.
I'll just ask this one first. So just in regards to, say, data, so what improvements to, say, data collection would enhance the capacity to monitor the impacts of policies and interventions on social groups? That's my first question to you, Jane.
I actually think when we often talk about data, and we have to remember that data is people's lives, and they're indicators of people's lives. And I actually think it's not actually about the being requested or instructed to, record A, B, C, D, and E about someone's life. It's actually about what is really needed is about supporting workers and organisations to be able to collect that information, to understand and to be able then to use that information to feed back into what they do in their own communities. And I think we quite often don't like collecting, workers, whether they're nurses, doctors, etc., don't like collecting that information because they don't see it as relevant. And I think if we work more towards around making it relevant for those communities and those populations, it would strengthen that data collection system greatly, and thereby showing the evidence in what we need to do to address inequity.
Okay, great. And also we have a question from Jen. Now, she noticed, as well as myself, that fire alarms was as an alcohol-related intervention. Could you provide more information on this? Because this is quite intriguing.
Yes, and Jen, Vilma and I actually had a quick discussion about this earlier in the week. And since then, I actually have gone and done a little bit more research on it. And it's actually, I've got this smile and I'm sounding passionate about it, but it's actually a really serious issue. So basically, there is very little work out there. Let me just take my glasses off because I've done notes on it. So basically, there's very little research in the area around fire alarms and alcohol. But what is really clear is the social, from my perspective, was that it really illustrates the social determinants of health in terms of at that household and community level. Because the risk of death from fire increases by a factor of 2.5 times if you're Aboriginal and Torres Strait Islander, if you live in poverty, if you're from low socioeconomic status, if you're male, and alcohol, 35% of fire fatalities in Australia in the last 15 years were associated, one of the risk factors was having alcohol in the system, and also other medications. So in terms of fire alarms, it's actually not, even though in a lot of states and territories, fire alarms are compulsory, that does not necessarily mean people have a working fire alarm, because batteries are actually really expensive. It may also not be that those fire alarms are in the correct place in a house, but also there is some evidence that that standard of what the fire alarm noise is, for want of a better word, is actually, that's just a basis. And so there may be a need in certain communities and in certain populations, particularly elderly people, particularly if there's known areas of alcohol use, that the level of that the fire alarm is actually much higher. Right. And of course, if you can't access a fire alarm, if you haven't got a working fire alarm, and also death rates are much more higher in remote communities, even though there's more fires in city areas, the death rate is higher in urban communities. So it's actually all interrelated.
Okay, great, thank you. And thank you, Jen, for that question. We have another question from Celeste. Can you give an example, and this probably ties in with the question before, of a socio-economic intervention that has been successful in Australia?
More broadly?
More broadly, Jen?
More broadly,
yep.
I'm thinking in terms of what we know around austerity. From the great financial crisis, we knew that austerity, when states went into austerity, that killed people. That more people, for example, in Russia, 60,000 males have just disappeared. I think one way that it has, particularly at the moment with COVID-19, is that injection of, despite what you may think in terms of the job seeker and the job keeper payments, by enabling people and how long it's taking some people to get that money, the injection of that back to people actually staves off that absolute poverty. And so that is something where the situation was amenable to change. Whether it will last, and we all know there's huge Centrelink, etc. But for that moment in time, the injection of that money has staved off potentially a lot of other problems for many people.
Right.
As a very recent example.
Yeah, totally. And we have another question here from Luella. She says, thank you very much for your very informative talk. My question concerns advice for medical students. How can we improve educational processes for I think med to address this issue?
I don't know. I personally think that it's a lot better than it used to be, because we are getting a lot more older people doing medicine. But I also think that it's right across the board in terms of whether you're talking medical students or nursing students or even social work students. I do know for a fact that in social work, they actually get very, very little information, very, very little education and training around alcohol and other drug use, and very little around cultural issues as well. Yeah. For example, I'm working with a colleague of mine in the School of Social Work, and of the 89 degree programs for social work in Australia and New Zealand, there's only 9 topics that are alcohol and drug related. So I think it's a systemic issue. We can't just blame, I would like to blame the nurse, blame the doctor, blame the social worker, but it's also, as we pointed out in the title of our paper, Kirsten and I, you don't know what you don't know. And I think a lot of students and nurses and social workers don't know what they don't know. And so I really don't have a short, simple answer for you, or simple answer.
Right, no problem.
Sorry, but I think we're all facing that same issue.
Yeah, that's true. And we've got quite a few questions. So
you told me there wasn't going to be many questions.
Got a lot of participants today, so
thank you for showing interest.
That's good. Now, we got a question from Aniki. What will be one way of building the capacity and number of workers in the AOD sector? That sort of ties in a little bit with the last question, but more specifically in the AOD.
There is, if you can get your hands on the Northern Territory PHN Workforce Development Strategy, that actually has, I think, about 100 different ways, simple ways that we can increase the numbers of AOD workers. That's the only one I know that's publicly available. But it's basic stuff in terms of, as we would have work experience for someone to go do teaching, let's say work experience for someone in year 10 to go and work with an AOD worker in a remote area for a week or 2 weeks. Let's be innovative about the sorts of positions that we have instead of expecting everyone to have a Cert 4 in AOD. Let's start right at the very beginning. Let's get people involved in different aspects so they don't have to be specialists in AOD to begin with. It could be about they're the ones on the phone contacting people, admin work, etc. So that report in particular has a lot of simple ways, both at a service provider level, at a policy level, and a community level for increasing the number of AOD workers. Because it's hard, and we all know it's all short-term contracts, short-term funding. It makes life really hard.
It does.
I've worked in the field for 20 years, and in one place I worked for 8 years, I had 13 contracts.
Oh, that's a lot. Yes,
yeah.
Yes, it's understandable. So thank you, Aniki, for that question. So, okay, so I think we've got time for a few more questions. Okay. We've got a question here from Ryan.
Ryan.
Okay, Ryan. He's asking, do you have research on the inclusion of holistic health interventions, including spirituality and cultural interventions, with respect and support from community elders, but particularly for youth? And what are your thoughts on this?
We don't here at NCETA, but I do know there's a number of traditional healers that have been appointed and are recognised within Flinders Medical Centre, who work not only with the general population, Indigenous people coming in who our age group, but with young people and with older people. I think when we look at AOD, we recognise, I think, in this sector probably more than anything, except maybe mental health, that it's all holistic. It's all part. The AOD use is only part of other aspects of people's lives, and we certainly know that spirituality is really important and crucial. My other area of expertise is actually around quality of life, and spirituality is a very, very important, it's a crucial aspect of what we'd call quality of life or the goodness of life. And I don't think we give enough credence or acknowledgement. I think in Aboriginal and Torres Strait Islanders, the Maori people give way more credence and way more acknowledgement of its importance to an individual and community's well-being. But they do have started, I think, particularly in South Australia, to include more traditional health approaches and well-being approaches. And I do know in Queensland they're trying to as well.
Thank you.
Am I answering these questions?
Yes, I think you are. I'm getting responses so thank you very much for the answers. So,
good.
So we have one from...
If I'm not very clear, please by all means email me and I'll try to be a bit more clearer.
No, that's fine. So thank you, Ryan, for your question. So probably have time for maybe just 2 more questions. Let's see, got one here from Kylie. Now, you said interventions need to address discrimination, stress, poverty, ongoing grief, the impact of trauma and colonisation, and that interventions that don't address these issues aren't likely to result in lasting change. But this is probably beyond the scope of many interventions. So how do you incorporate addressing the social determinants of health with an intervention? For context, I work on a school-based alcohol and prevention program.
I think particularly from an AOD worker's perspective, and if we're working in AOD work, I think one of the biggest barriers for us is actually stigma around the work that we do. And it's actually partly about acknowledging that we do damn good work, that we are there to facilitate and support individuals and also indirectly their families and communities. And I think part of addressing one of the real ways that we can as a worker is to manage the taint, so to speak, of working in AOD, and actually seeing and recognising that what we do is really effective. There's a lot of evidence for it, and it makes a difference to individuals' lives, but also to families' lives. And I think we quite often, that's part of taking, I think, part of that social determinants and that inequity of saying things are able to be changed, and it's about us standing up and going, well, what we do is good work. We can do better, but we also do good work. And that's part of shifting that balance of the imbalance that exists.
Right. So thank you, Kylie, for
that. Personal view is about dealing with the stigma first and foremost.
Yeah, understandable. So thank you, Kylie, for that question. So we have time for just one more question. This is another one. We don't have the person's name, but that's okay. So the Northern Territory is very focused on a floor price for alcohol and having a police presence outside bottle shops and restricting hours. So what have you presented? What you presented indicates that this is not the most effective strategy for dealing with alcohol issues in our communities. So how do we get the social determinants of health in this discussion, which allows us to address the underlying issues?
Fortunately, at a national level, we do know that pricing makes a difference because it decreases availability. From the evidence around floor pricing that I can recall from the Northern Territory, it has made a difference in overall harm and risk. But you're absolutely right. How do you address that at a local level when you've got police standing outside of basically policing your own behaviours, your individual behaviours? And the only thing, I mean, personally, I would be quite offended by it. And I'm not someone who, it's just that human right, that sense of social justice about, it's almost like you're guilty before you actually enter the place. And I think it comes down to those bigger issues around how that policing occurs, and possibly even those collaborations between AOD around health and the police, and also other departments and other people within a community as well, around that consultation about how it should be and how it should work, and a bit of a balancing act as well. So unfortunately, on the one hand, yes, we know that and internationally prices make a difference, but how that works actually on the ground and how that translates into practice is quite different. And I was a Queenslander brought up under Joe Bjelke-Petersen, so I completely get that whole idea of police being right there.
Yeah, that's true. So thank you for that question. Okay, so we're coming up, sorry, but unfortunately we can't ask any more questions. We'll be coming up almost to the end of our session. So we'll just go to the next slide. And, oh, excuse me while I adjust my seat. And so you can also find out more information on the Alcohol and Other Drugs Knowledge Centre website. And there we have a page dedicated on alcohol, which has key facts, resources such as prevalence, prevention and education, regulation and control, treatment support, as well as information for young people. And they're all located under the specific drugs in the Learn section of the AOD Knowledge Centre website. And you can also find the link for the review of the harmful use of alcohol among Aboriginal and Torres Strait Islander people, which is the video. You can find this on this page as well. And also just to note that the Alcohol the AOD Knowledge Centre is also working on our tobacco review, so this will be available very shortly. So we'll just come up to our finishing slide.
We've also got this as well,
Oh,
which
yes.
is an NCETA, Feeling Deadly, Working Deadly for Indigenous AOD workers, but workers around in other areas have also found it to be particularly helpful.
Yeah.
So just email me and we'll send one out to you.
Yeah, and we've also got that on our website as well. No, that's no problems. So I'll make sure that everyone gets a copy of that, and that's a good plug there, Jane. Thank you for that. That's no problems at all. So we'll just come up to, oh yes, please, thank you. Okay, so thank you everyone for joining us today and being part of this AOD Knowledge Centre webinar, and a special thank you to you again, Jane, for that great presentation. We really appreciate it and taking the time out to present for us, especially under these circumstances. And we'll hope to meet in person. So
yes, that would be lovely.
It will be. And if anyone has any feedback or would like to forward some questions or queries, please contact us. Please note that this webinar will be available as a recording and a PDF handout in the future. And make sure you subscribe to our monthly newsletter for the latest updates and news on AOD, and to find out when our next webinar is on, which is actually next Thursday on the 21st. And that's with Dr. Julia Butt. So thank you everyone, and have a great day. And more importantly, stay safe. And we'll be switching off. So thank you, Jane. And goodbye, everyone.
And goodbye. Thank you for participating.
Yes, thank you everyone. Bye.
Bye.